We'll start now. Karthik from our PMT team will start the formal meeting. Right now, we have 113 doctors logged in. So, Karthik, over to you.
Karthik, you are mute. Please unmute yourself.
Sir, am I audible right now?
Yeah, you are audible. Please continue.
A very warm welcome to all of you today's webinar on an important and evolving topic, which is EPI in diabetes. This session will shed light on the prevalence, pathophysiology, diagnosis challenges, and treatment options for the EPI in context of diabetes. It is my honor to introduce a well-known esteemed doctor, Director of Pancreatology, Asian Institute of Gastroenterology, Dr. Rupjyoti Talukdar, and esteemed panelists who bring a wealth of knowledge and expertise to this discussion. Dr. Jayanti, Dr. Ajay Kumar, Dr. Suhas, and Dr. Sujay Ghosh. So I would like to hand over this session to our moderator, Dr. Rupjyoti Talukdar. Over to you, sir.
Hello, very good afternoon, good evening rather. So I think this is the second webinar. The first was on acute pancreatitis, the first week of management. I think it went very well. We had some of the strongest and most powerful people from all over the field, like gastroenterology, endocrine, in ICU, critical care, surgeon. And then I think the second one is a very apt topic that we are doing today, EPI in diabetes. We'll go into that in more detail. But first, let me just introduce our panelists today. And I think they are who's who in their own field. So I'll just pull out the slide and okay, just a sec. Okay, so where is the So is the slide visible?
Yes, sir.
Yeah. So
yes, sir, it is visible.
Yeah. So the first panelist is none other than Dr. Shashank Joshi. So there are several sentences you'll see, but I will not read out everything. I had picked up few with yellow highlights. So he's an internationally acclaimed endocrinologist and clinician scientist. He was a Padma Shri for excellence in medicine way back in 2014. He's currently the chairman of the International Diabetes Federation Southeast Asia, past president, International College of Nutrition, has over 1,000 research articles, and he had several leadership roles. Some of them had been president of Indian Academy of Diabetes, past president of Endocrine Society of India, Indian Thyroid Society, API, RSSDI, and several others. Next, we have Dr. Jayanti Venkatraman, our very dear and favorite madam. She again has been associated with the practice of gastroenterology for several years, more than 3 decades, almost 4 decades. She had been a former professor and head at the Stanley Hospital in Department of Gastroenterology. Her research interest was hepatology from yellow phosphorus. But what is not written in this slide is she is one of the best teachers of gastroenterology we have ever seen. Till now, she creates fabulous classes for the DNB students, and she is present at all the educational programs that are done for the DNBs and DMs in the country. So that I think that's something very great, and we all respect you for that, madam. Dr. Ajay Kumar, again, almost 4 decades of experience in gastroenterology. Currently, he is the chairman of gastroenterology and hepatology at BL Kapoor Max Super Specialty Hospital, New Delhi. He was awarded the BC Roy Award by the President of India in 2008. And another accolade to his honor was the International Service Award by the American Society of GI Endoscopy, ASGE. So he had held positions of chairmanship at Fortis Escorts Liver and Digestive Disease, executive director at Fortis. So he's a great thinker. And in fact, many of my research ideas actually comes from his thought process and his debates and discussions and critical thinking. So thank you, sir, for that. And then we have Dr. Subhash.
I will have one correction. There's written some 6,000 papers. 60 has been converted into 6,000 there.
Okay, I think I okay. Where is it? Okay, I think I didn't say that. I mean, okay, yeah. Dr. Rande is a member of the American Diabetes Association. He is the director of Akshay Hospital and Insulin Pump Center. Has done great work in the Pune area on the awareness of diabetes, and he has received the Diabetes Mitra Award for 2016. He is a national faculty of almost all the important diabetes and physicians meeting in the country and the other countries around. And finally, last but not the least, Dr. Sujay Ghosh is a professor at IPGMR and SSKM Hospital in the Department of Endocrinology and Diabetology. He's a fellow of the American College of Endocrinology, published very well, published with over 300 papers. And he had actually had some social program where he launched a structured health program for type 1 diabetes management in West Bengal. And he had received the AACE Outstanding International Clinical Award. So this is the profile, or I'd say the strong profile of today's panelists. And I think we can directly go ahead to the case proper. And let me pull out the slides. Yeah. Yes. Okay, so since we are all clinicians here, I think it would be apt to begin a whole webinar or speakers and the panelists. So basically, we are going to discuss about an entity called exocrine pancreatic insufficiency in diabetes, and it's like this uncharted terrain. This entity has been there since diabetes first came into existence. We know about exocrine insufficiency in chronic pancreatitis, in cancer. It is very well described, very well debated, and several treatment modalities are available. But in the context of type 1 and type 2 diabetes, it is not well known, because there is a saying called what the mind doesn't know, the eyes doesn't see. So this is the main goal of today's webinar or panel discussion, is that to create awareness of this entity. We'll talk a little bit on the pathophysiology, basically the exocrine endocrine crosstalk, which is responsible for the pathophysiological events, and then the imbalance that happens between this crosstalk. How this endocrine dysfunction in diabetes happens, and some of the clinical features, and how exocrine supplementation can help in these patients. Let's come to the case. So this is a 58-year-old male. He had been diabetic for 12 long years. Initially, he was treated with OHs, but eventually he had to be put on insulin. There was fair glycemic control, HbA1c around 7.5. But he started having recurrent diarrhea for the last 6-7 months. There was progressive weight loss. So someone rightly did a stool routine examination, which was normal. There was no parasites and other abnormalities. So here, let me bring in Dr. Sujay Ghosh. At this stage, what would be your thought process? I mean, how do you approach this diabetic, good control, but recurrent diarrhea, progressive weight loss?
Thank you so much for having me on this program, and thank you for that question. I would first like to talk about, this is a pretty common situation.
Yes.
One of the things that we would think of firstly would be metformin intolerance, because that's probably, in terms of commonality, the commonest thing. The second would be, autonomic dysfunction, and of course, pancreatic insufficiency would be one of the other possibilities. So apart from all other possibilities that can happen in any individual. So these would be, the weight loss is not that prominent with the metformin though, but that would be one of the things. But the kind of photograph that you've put up on, unless and until there is maybe uncontrolled diabetes with additional infections like tuberculosis or otherwise, you would not expect this kind of weight loss. So because today's program, probably all roads will lead to pancreatic dysfunction and dysfunction. That would definitely be there. But given the
Yeah.
commonality of diarrhea with metformin, I think it still stands at number one.
Yes. Okay. I think that's a right way to approach this. So he was treated with multiple courses of rifaximin, probiotics, but again, the responses were suboptimal. So at this point, I'd like to call upon Dr. Jayanti. So would you like to add on anything more at this point?
I think I endorse the views of Dr. Sujay because I think the most common cause that we have encountered is usually an autonomic entropathy with bacterial overgrowth.
Yes.
But it was very interesting. All along, metformin has always been the first line of drug of choice in patients with diabetes. But it's only of recent onset for the last 5 or 10 years that we are finding this metformin-induced diarrhea with a crampy abdominal pain. I do not know the reason why all this has come all of a sudden. But in this particular patient, I think the DD would be first long-standing diabetes, bacterial overgrowth due to autonomic entropathy. And if we have some more information, of course, other causes like metformin-induced celiac disease, IBS and all also should be considered, provided we have a further detailed history. And exocrine pancreatic insufficiency is an important differential.
Yes. So a good history was taken. Like at this point, actually, the patient actually had come to AIG and somehow landed in my OPD. So we had made a group of the endocrinologist, and I was looking. And when we took a history, actually, what turned out of all the other history of his weight loss and other factors, he gave a history of loose, bulky, foul-smelling, pale, floating stool. Of course, patient won't give such detailed history, but we had to poke him and ask in details about his stool, and this is what came out. So this was the typical history of what we call steatorrhea in technical terms. So this patient now has long-standing diabetes with fair control with recurrent diarrhea and progressive weight loss, and now he was on insulin, not on metformin. And then he had a history of steatorrhea, and his diarrhea was not improving with any kind of antibiotics and probiotics. So this means that something in the exocrine function of the pancreas was going on, and we had started him on pancreatic enzyme replacement therapy. And in fact, in 2 to 3 weeks of time, he had shown some benefit. The steatorrhea was less, and then he clinically improved. And glycemic control also seemed to be improved a little better after starting the exocrine replacement therapy. Again, we can discuss that if really this has contributed to the glycemic control. That's again debatable, and we can discuss further as the panel discussion goes. So now the patient has exocrine pancreatic insufficiency in the background of long-standing type 2 diabetes. So here, Dr. Rende, could you tell us what does it mean actually? What is the EPI, or how we define it for the interest of the general physicians?
Yes, sir. So I believe that the entity is something where probably the index of suspicion should be certainly high.
Yes.
And it will be technically called as a definition which has lots of debates and lots of discussions going on in the field of gastroenterology specialists and the world bodies. But this generally say that it's a reduction in the quantity and or activity of the pancreatic enzymes to a level which is inadequate to maintain the normal digestive process. Or some people say that it's a reduction of the pancreatic exocrine activity in the intestine at a level which cannot satisfy the normal digestion. All these should be on the background of course, symptomatology of the patient and some kind of pancreatic issues, which may be the reduction in the pancreatic mass, or maybe something which is a disease which is affecting the whole of the pancreas or most of the pancreas, like maybe chronic pancreatitis. Pancreatic cancer, generally they say that though it is maybe a only tail of the pancreas or maybe a small tumor, let's say, it may not really result into EPI, but generally adenocarcinoma can. And of course, the surgeries, resection of pancreas for whatever reasons, partial, subtotal or total, that can certainly result into EPI. And of course, there are if there is an obstruction of pancreatic juice to come into the intestine, maybe because of a tumor of the ampulla of water or the ductal carcinoma, or decreased endogenous secretion or stimulation because of celiac disease, Crohn's disease, long-standing diabetes mellitus, especially type 1, intraluminal destruction or inactivation of the pancreatic juice in a high acid environment, typified by Zollinger-Ellison in an extreme case, and maybe then the gastrointestinal motility, if it is affected, gastric resections, short bowels, Crohn's, etc. And of course, autonomic neuropathy, which has already been alluded to. So these backgrounds can certainly make one suspicious about possibility of exocrine pancreatic deficiency or exocrine pancreatic insufficiency.
Yeah. Yeah, I think so. This slides again shown whatever Dr. Rende has already told us, mechanism-based and etiology-based classification, loss of functional parenchyma, inhibition of activation, and some asynchrony. And here, if you see in the diabetes, under two mechanisms, we see diabetes mellitus. One is inhibition or inactivation of pancreatic secretion. And again, we'll go into more details into this as we go ahead in this discussion. And then again, post-cybal gastrointestinal asynchrony, which again reflects the autonomic dysfunctions. So now we know now that EPI in diabetes happens, but what about the situation in India? So this was a question for Dr. Shashank Joshi. I don't know if has he joined?
No, sir, he is not joined yet, but sir will surely join, sir. You can take it up, sir.
Okay. Okay. Yeah, no problem. So basically, Dr. Shashank Joshi had actually recently published a very beautiful paper on EPI in diabetes in India. So let's look at some of the data. So this slides actually show very old studies which EPI in diabetes was detected based on direct test. Direct test means to see the direct function of the pancreas, like pancreasymin, secretin stimulation test. And what you see here, again, I will not take you through each rows, but if we take the results as a whole, up to 80%, from 27 to 80%, a wide range of patients with diabetes, both type 1 and type 2, has pancreatic exocrine insufficiency. So these are old tests, direct tests, which are not available anymore now. And then if we look at the indirect test, most commonly a test called fecal elastase was used. A definition of less than 100 microgram per gram of stool was used. And if we see here again in type 1, type 2, overall 50% of these patients had pancreatic exocrine insufficiency. And this is again a more recent study, a systematic review. Again, fecal elastase of less than 200 was used. 17 studies, over 3,500 patients. And here, probably this is a larger pool of patients, and I think this is more closer to reality. More recent studies in type 1 diabetes, almost 40% of these patients had EPI, and in type 2 diabetes, almost 30% had EPI. There has been a study from India several years back, almost 10 years back, from Bangalore. Dr. Prasanna Kumar and his group conducted this study, and here they had 89 type 1 diabetics and 95 type 2 diabetes and 90 healthy control. This is very important. I mean, to have a healthy control in this kind of a situation so that we get the real signal in the disease population. And again, if we see the prevalence of EPI in type 1 diabetes was 30%, and the same was the incidence in type 2 diabetics. And there was significant correlation between HbA1c and the EPI status. So this is a real entity, and now from this study we know that PEI actually exists in Indian diabetics. And now let's come to Dr. Shashank Joshi's paper. I thought if you were here, he could have explained it in a much better way. Here, the beauty was a large sample size. There were 300 patients. I think one patient, the samples were not there or something. So 299 patients were analyzed. It's a multi-center study. I think centers from Kolkata were also involved. We see Dr. Subhankar Chaudhary's name here. So 53 years was the mean age, 60% of males. Duration of diabetes, they have long-standing diabetes. And again, if you see the prevalence of EPI, overall it was 23.8%, then type 1 and type 2 again both 23%. So if we see this study and the previous study, almost 1/4 of the Indian diabetics do have EPI. So it's a major problem, because 25% diabetics patient having this problem is a big number. And that's why it's important for all physicians, diabetologists, gastroenterologists also to think about this entity when they're taking care of the diabetic patients. So now we had been, I had initially told we'll talk a little bit about the endocrine-exocrine crosstalk. So usually endocrinologists and exocrine pancreatologists or gastroenterologists, I mean, they work in isolation. I mean, they have their own departments and own branches and have their own ways to handle this patient. But it's very important to understand that there is strong crosstalk between these two components of the pancreas, and it's therefore important to work in tandem with each other. So here again, I come back to Dr. Sujay Ghosh. So can you throw some light on the interaction, how these exocrine and endocrine components of the pancreas function together?
Right. Just before that, I would just like to add something to what Dr. Jayanti ma'am specified about metformin.
Yeah, sure.
Two reasons I believe why
Sure.
the diarrhea has increased. One would be because we are using much higher doses of metformin nowadays. Previously, more people were inclined to using, say, 500 twice a day. We are much more aggressive. We are using 1000 milligram twice a day kind of thing, number one. Number two, a lot of the newer drugs come with a combination with metformin, where the metformin is an immediate release preparation, which actually messes things up more, because if you switch the immediate release to a sustained release, at least 2/3 of people who are having diarrhea, they will respond. If you cut down on the dose, they will respond. So that's a little bit of addition to what ma'am has already talked about. Now, when we talk about this interaction of the endocrine-exocrine crosstalk, we've got to understand that it's a two-way process. It's not just the endocrine thing influencing the exocrine or the other way around only. So if you're talking about the islet hormones, how do they influence the exocrine secretion? The most important one would actually be insulin. You know, insulin is trophic for the acinar cells, and it helps in the acinar secretion. It is through a genomic pathway. It's not a non-genomic pathway, so it takes time through the messenger RNA pathway, creation of protein and the Golgi bodies, through which it actually looks after the health of an individual acinar function. So in type 1 diabetes, this could be one of the things that might be one of the reasons why we are talking about, you know, because type 1 is relatively more specific for a beta cell destruction, and yet we are seeing that many of them are having exocrine pancreatic deficiency. That's number one. The glucagon is perhaps not necessarily a very direct effect, because, you know, if you're looking at the GLP-1 analogs that we are using currently, like say liraglutide or the other drugs, though I would be very cautious about using those drugs in cases of pancreatitis induced diabetes, but the other type 2 diabetes where you're using these GLP-1s, they actually have an effect on the proliferation of the acinar cells. If you're looking at the other hormones, for example, somatostatin, pancreatistatin, and pancreatic polypeptide, they are more inhibitory, of them the somatostatin having perhaps the biggest role in terms of the inhibition of the exocrine.
Yes. Yeah.
Now, when you're talking about particularly the GLP-1 pathway and the incretins, we've got to remember that nutrient in the gut does not cause incretin secretion. Nutrient absorption causes incretin secretion. So
Yes.
if you have got some form of malabsorption due to whatever reasons, the amount of nutrient that gets absorbed from the intestine is reduced. If that is reduced, then the incretin secretion goes down. So it's a cycle. So if the incretin secretion goes down, you get the GIP, GLP going down, the insulin going down, and the exocrine function probably even worsening. That could be one of the potential mechanisms. The other mechanism by which we often explain is change in gut microbiome. So the gut microbiome per se might be altered in the different types of diabetes that we are talking about, particularly where you have got exocrine dysfunction. And if you've got exocrine dysfunction versus a normal intact exocrine function, the incretin effect is different because it's the absorption of the short chain fatty acids which probably induce incretin secretions from the pancreas. So it's all interrelated, and it's not just that one mechanism could probably explain the interplay between the endocrine and the exocrine function.
Yes, I think yeah, you have covered the whole thing in a very succinct and short way. Just to show something interesting. So we all have learned from our MBBS and basic pathology, physiology about glomerular system, which we all know is seen in the kidneys. But there is something called the insulo-acinar capillary system. So this is electron microscopic cast image of pancreatic islets, and this is how you see. So these are also called glomeruli. So where blood flows from one capillary, one venule and break into capillaries, and then again forms another bigger vessel. So this pancreatic islets also have this glomeruli, and then this is how all the blood that gets into pancreas will always go through the islet. So this is the beauty of the islet constitutes a very small proportion, but it has the maximum blood, and all these islets will secrete the hormones, insulin, glucagon, and all the other. And insulin, as Dr. Sujay has already said, it's a trophic effect is there. So when it goes and bathes the acinar cells, acinar clusters around the islets, they will be bigger in size, and that is called the halo effect. If you see here, so this is the islet, and all the acinar cells around this islet have more of zymosin, as indicated by the black color, and these are bigger in size. So this halo effect shows that, proves that this insulin has a trophic action on the acinar cell. And then again, there are receptors of insulin in the acinar cell in the basolateral surface. And again, he talked about the Golgi apparatus and the translational machinery. And when insulin gets bound to this receptor, they leads to increase in acinar secretion, increase in their size. And so this is an important crosstalk. And again, we just heard about a GLP receptor. Everyone has some amount of worry about giving these in patients with pancreatitis, especially acute pancreatitis. And in fact, GLP-1 analogs have been labeled as a cause of acute pancreatitis, but there has been debate. And this study actually is very interesting, published in Cell Reports around 10 years back. So the acinar cell surface has receptors for GLP-1 analogs. And again, these are experimental details. I won't go into the details, but this binds to this receptor, and they can cause proliferation and increase in amylase, lipase, and other acinar secretion production, acinar enzyme hormone production. So you'll see many of these patients who you treat with GLP drugs will have high amylase levels, but they do not necessarily have inflammation in the pancreas. So this study actually tells us there may not be a real cause or if just a pharmacological effect. And those patients may have pancreatitis because of the other risk factors. They are already diabetic, hypertriglyceridemia, gallstones. So they are probably responsible for their pancreatitis. Still debatable, but then there has been a little sway towards them not being a hardcore cause of acute pancreatitis has been building up over the last few years. So this is an important thing, I think. And again, microbiota we had already heard. And then we had actually shown in some of our recent studies that the microbial dysbiosis in type 1, type 2, and type 3 diabetes are totally different. So if you see here, in type 1 diabetes, there are 35 unique species which are not seen in type 2 and type 3C. And similarly, there are 39 unique species in type 2 and 63 unique species in type 3C which are not common with the other two types. So gut microbial dysbiosis has a role. Not sure how much it contributes to the exocrine insufficiency, but then there has been some studies that show some association. So if we link all the whole thing, the insulo-acinar capillary system, the enteropancreatic axis, so this is where the crosstalk comes. So the pancreas will lead to insulin, which enhances exocrine secretion, as we have seen. And again, the enzymes from the pancreas would lead to nutrient digestion. Again, Dr. Sujay has beautifully told that it's not just presence of food in the intestine, but it's the absorption. So so there will be these enzymes will cause digestion, there will be absorption. And then the short chain fatty acids from the dietary fibers will also activate the GLP or the this GLP cells. And then this incretins will lead to maintenance of euglycemia. So this is the whole circuit that actually we can fit into the whole scheme of events of how the exocrine and endocrine system talk to each other. So now I come to Jayanti ma'am. So what do you think are the mechanisms which drives the development of EPI? So what we talked just now was the physiology, how the crosstalk happens. Now, there has to be some pathological mechanisms for the abnormality to happen. So I'd like to invite you here to give your thoughts on how this EPI in diabetes happens.
Yeah, so can I have the next slide? So basically, I think discussing is on the pathogenesis of type 1 diabetes mellitus, right?
Yeah.
And this is largely related to the presence of autoantibodies against the exocrine antigens. I think that's the most important point. In the presence of a genetic predisposition, as you can see in this slide, there is, in the presence of a basic genetic trigger and a putative trigger. So if you have a trigger in a patient who's got a genetic predisposition, there is what is called as, this results in insulitis, and this results in a cellular autoimmunity. This results further in occurrence of circulating autoantibodies. Over a period of time, there is loss of insulin response, and this is probably the first phase that results in an abnormal glucose tolerance test, and diabetes sets in over a period of time. So I think what we're discussing here is largely a type 1 diabetes mellitus. Next slide. Can we have the next slide?
Yeah, so here, if I may, ma'am, I'll just add in one point. So we usually, in the context of type 1, talk about beta cell autoimmunity, anti-GAD, but then up to 75% of patients also had autoantibodies against the exocrine antigen, against the acinar cell antigens. So that leads to acinar cell apoptosis and reduction in the secretion. So one because of low insulin, the trophic action is gone. And secondly, because of destruction of the acinar cells because of apoptosis induced by autoantibodies, again, the secretion comes down further. So here I'll take you to the next slide. Yes, so this is on type 2 diabetes.
Just in the previous slide again, all that we discussed type 1 would remain the same. The same pathogenesis would remain for, say, tropical calcific pancreatitis and type 2.
Yeah.
I had a doubt, because for us as gastroenterologists, we see more of steatorrhea due to a tropical calcific or idiopathic calcific pancreatitis rather than type 1 diabetes, which is, I think, in the purview of diabetologists.
Yeah, so in type 3C or the FCPD, tropical, whatever we call it, tropical. So there actually we have figured out some pathogenetic events. What we have found, actually we have published this like in 2018, I guess. There is infiltration of T helper cells, Th17 cells, which converts into Th1 cells, which secretes interferon gamma. And that interferon gamma actually activates the JAK-STAT pathway. And we all know that PDX1 is responsible for insulin gene transcription, right? I mean, whenever the glucose binds to the receptor on the cell wall, there is a PI3 kinase activation, and phosphorylation will lead to PDX to get into the nucleus. And then all the insulin is produced. But when JAK-STAT activation happens, it exteriorizes, it removes the PDX from the nucleus to the cytosol. So insulin gene transcription doesn't happen. So that is a very early mechanism that we have seen. And recently we have reported a receptor called the NR4A receptor. Again, that is also responsible for this JAK-STAT pathway activation. So that is kind of what happens in type 3C or FCPD. And now this is, ma'am, this is type 2 diabetes again.
So in type 2 diabetes, I think we have a pre-diabetic phase which lasts for almost 5 to 10 years, even before the onset of the frank diabetes. And this is the time when there's insulin resistance with impaired fasting glucose levels. And I think with the onset of diabetes, insulin resistance increases. There is further a decrease in insulin secretion. Both fasting and postprandial blood sugars also start increasing. And this results in a cascade of cardiometabolic events. And this is probably responsible for the various microangiopathy changes that take place, as well as the cardiovascular complications and so on and so forth. And I think histologically, as has already been alluded to, even in type 1, there is an increase in immune cell infiltration in exocrine pancreas. And this slide beautifully highlights the changes in pancreas in patient with diabetes and exocrine pancreatopathy. There is a decrease in pancreas weight. This has already been alluded to. The volume also decreases, and size in type 1 diabetes with fibrosis and minimal inflammation and hyalinization of the arterioles. These are the changes. I think this we have already discussed, but this slide shows all these changes.
Yeah. So Dr. Chari actually coined this term diabetes mellitus of exocrine pancreatopathy. So he had done extensive literature. And if you see, there is fibrosis in type 1 diabetes, inflammatory cell infiltration, but not as severe as chronic pancreatitis. So, and in the arterioles also, there is hyaline deposition, thickening of the arterioles. So I think this is a real entity which drives the progression of exocrine pancreatopathy in these diabetic patients. So again, ma'am, I would like to.
Yeah, because this is all in electron microscopy picture.
Yeah, so again, basically the gap between the exocrine and endocrine cells increases. This is a simple message. If you see, the extracellular matrix widens, and since the contact between the exocrine and endocrine cell goes away, the trophic action also goes away. The vascularity in the matrix comes down, and that again leads to the reduction in the trophic action of the insulin on the islets, on the acinar cells. So basically, it's a complex study, but that's a simple message. I mean, there is change in the extracellular ultrastructural abnormalities happens. So I think this is a summary, ma'am, if you can take us through this of how all this.
Yeah, this is, I think, the most important slide that summarizes all that we've discussed so far. Basically, there's loss of exocrine function, largely due to the loss of trophic action due to insulin deficiency. There is tissue ischemia due to microangiopathy. There's loss of neurohormonal signal due to neuropathy. And finally, there's a pan-glandular dysfunction due to inflammation. I think all that we discussed is beautifully summarized in this slide.
Okay, so yeah, so any of the panelists, if you want to add anything, Dr. Sujay, Dr. Rende, Ajay Kumar sir.
So my question is, all these changes occur only in type 1, or does it occur also in type 2 diabetes as well?
Yeah, mostly in type 1, but as the type 2 progresses, it starts behaving like type 1. There will be glucotoxicity, it leads to beta cell damage, right? I mean, so as the disease progresses, even in type 2, these changes will happen. And otherwise also, there is inflammatory cell infiltration in type 2 diabetes. It follows the NF-kappa B pathway and other molecular pathways. So in type 2 also we see, but if we go by the general scheme of events, and it seems to be much more and faster in type 1 compared to type 2, but we do see in type 2 as the disease progresses.
Actually, what you have talked
so
about.
Now, yeah, sir.
Yes, I said it's a wonderful shown that so-called entity called diabetic exocrine pancreatopathy. I mean, I think that corresponding to that, I think you mentioned about Suresh. He also talked about the different levels of pancreatic exocrine dysfunction.
Right.
You coined the term dysfunction, and out of 4 different stages, about the insufficiency PEI as the one which is causing vitamin deficiencies and requiring treatment, while the first 3 stages of dysfunction, one thinks that there is a pancreatopathy, but probably not significant enough to require therapy.
Right. So basically, the exocrine secretion is like 29 to 10 times more than what we really need, right? So if it is within the like proportion, like if it's 50%, 60%, they may not be clinically significant. Only after 80% of loss, the patient becomes symptomatic, and that is where the 4th grade, the last stage of exocrine pancreatopathy or PEI, as Sir just said. Okay, so now we know the physiology, the pathology, and we know that this is a real entity. Yes, ma'am?
So
yes, ma'am, you're saying something?
Between type 1 and type 2, where would you expect EPI to be more?
in type 1 and very long-standing type 2. So,
thank you.
Yeah. So now the question is, the problem is, I mean, this is a real entity we have all realized. And I know all of you see this kind of patients, but sometimes we don't tend to think because the other possible causes takes the upper hand. And the other problem is there are no guidelines in the context of diabetes. There are guidelines in the context of chronic pancreatitis, but not in the context of diabetes. So we really don't know which patients to take up, which patients to follow, which patients to test. Will it be rational to test everyone? Again, we'll realize this when we come to the next slide. And whom should I test? So here, again, I'd like to ask Dr. Shashank Joshi. I think he has not yet joined. So when we suspect the possibility in the diabetic patients, we had discussed the pathophysiology, the duration. So again, someone had earlier said this high index of suspicion. And this is a very important statement. We have to try to proactively think these patients could have EPI, exocrine insufficiency, and some of the red herring signs, some of the red flags would be insulin dependence. If the patient has poor glycemic control, even at high doses of insulin, elderly age, duration of disease, long-standing disease will have more both morphological damage, atrophy of pancreas, and the other cellular injury will also be more, microangiopathy, autonomic neuropathy. So if these factors are present, it's important to think, okay, these patients could have exocrine insufficiency and they need to be tested. Of course, the other factors has to be ruled out, but the index of suspicion should be very high. Now, Ajay Kumar sir, this is for you. What causes the symptoms? I mean, if we know the causes of symptom, probably we can plan our investigation accordingly. And should physicians, I know you're very interested in this concept of subclinical EPI, and it of course has impact on the patient's health, and you have given great talks on that, which you have appreciated. So should the physician who look after diabetes be aware of this entity called subclinical EPI and the impact of EPI beyond malnutrition? I mean, that is what we usually think of, no enzyme and malnutrition. Is it something they're beyond?
See, as far as the symptoms are due to the malabsorption, maldigestion, and that's whenever these symptoms are there, the symptoms are also non-specific and overlapping with what Dr. Sujay Ghosh said earlier, that there could be overlapping with autonomic neuropathy, the drug-induced SIBO, because the symptoms are such. That is discomfort, dyspepsia, flatulence, bloating. I mean, these are the major symptoms which are will make you suspect. The question that you asked earlier, that should we start testing when you have these symptoms? Should physicians who look after diabetics be aware? Yes, they should be aware. But the question is, what do you do? Because right now, you rightly mentioned there are no guidelines. We understand the negative aspects of this maldigestion, but we do not understand that if we treat that, how it's going to improve the outcomes, right? So unless we have an established pancreatic exocrine insufficiency like steatorrhea, short of that, it will be difficult to justify start testing and treating for that. I hope I answered the question clearly.
Yeah. So, and what about the impact of EPI beyond malnutrition? I mean, other organ involvement,
yes,
cardiovascular.
There is enough evidence to show that it does increase the morbidity and mortality, especially the cardiovascular, and if not well taken care of. But that is well shown in an established exocrine insufficiency. I'm not sure whether, I think we need more data to show that it will cause dysfunction otherwise. So, that's, but yes, we have to be aware of it. And I think we need more data to show that.
So I think this would be more important for the physicians and endocrinologists, diabetologists, because diabetes is inherently related to cardiovascular comorbidities or mortality. I think the physicians and endocrinologists would be a good space to begin a study on this. We as like pancreatologists or GI people do not get this combination much, but the physicians should be in a very right position, I think. What do you agree, sir? So that they can do a very structured study to see the link between EPI and I think we don't have that data from India. And I think this is a good platform from where we can start thinking on some nationwide observational study. I mean, that could give us our Indian perspective.
People have postulated, especially the Spain Munoz et al. And that arguments in favor of enzyme replacement in occult, we call it occult exocrine insufficiency, that it shortens the patient's survival for over 20 years. Commonest cause of death is cardiovascular. And premature atherosclerosis is common. And it also decreases HDL, decreases apolipoprotein, decreases vitamin and micronutrients. And so, though we know that these are correctable, but we need to show that it actually works. And so to normalize any level of fat indigestion, will it help the patient or not? Because it increases a lot of cost to the patient. So whether we should test for the occult PI or not, and whether we should treat or not, will depend upon the data which need to be produced by the physicians.
Yes. So now, how to make a diagnosis? We had discussed, I mean, just now, Ajay Kumar sir excellently told the dilemma. I mean, if you get a positive occult, I mean, a test, fecal elastase or whatever, what to do? Is it really going to help? So how to diagnose or how to prove actually these patients had EPI? So Dr. Render, this is for you. How do you work up for EPI in the patient of diabetes? Now you suspect the patient has potential.
Let me put on the mask of a typical physician diabetologist here. And what Ajay Kumar sir just now was talking about, a gray area or an ill-defined area as of date. So as a diabetologist, if somebody comes to me, what patient you have shown, Sujay has already alluded to a lot of things. So I first think of uncontrolled diabetes, which is maybe making him lose a lot of weight, maybe because of possibility of tuberculosis. That is another important thing. Thyroid dysfunction, especially hyper in a lot of cases. And maybe some drugs, like these days, we use a lot of sodium glucose co-transporter inhibitors, the SGLT2 inhibitors, or GLP-1 receptor agonists, which make the patient lose weight. In fact, they can make the patient, especially SGLT2 inhibitors, certainly can give us some amount of weight loss, which is muscle loss also. So we have this background understanding. On the top of that, if the patient has some bowel or maybe abdominal complaints, and which could be probably, for the clarification, steatorrhea, loose stools, or presence of undigested food particles in the stools, and then we try to look at the workup, that will be something which is our standpoint from the diabetologist physician point of view. The words like malnutrition, which is reduced food intake, impaired digestion and assimilation, confounded by inflammation. Maldigestion is something which is incomplete breakdown of the nutrients due to lack of pancreatic digestive enzymes. And malabsorption is something which is impaired transport of nutrients from intestinal lumen to the body. So this is for the semantics clarification. Come to the test, PFT or pancreatic function test. We have two kinds of tests broadly for the description. One is, of course, the direct test, and the other is the indirect test. So if we really take into consideration the direct test, then this is an irony, I would say, because there is a need to really put in either an endoscope, which of course all you experts are doing, or there is a tube, oral duodenal tube called as drilling tube, which needs to be put in, and that is to really, you can say, assess the collect the pancreatic fluid and assess the pancreatic enzymes which come out of the ampoule of water. And this is after a stimulation of secretin or a cholecystokinin. So this is something, and of course the bicarbonates also. So this is very cumbersome and something which the patients really on a large scale may or may not really accept. And then there are some indirect pancreatic function tests. The most discussed, so to say, is the fecal elastase. Fecal elastase is something which is to be done on a solid stools or not on a loose stools. It has to be done on a background of suspicion. That's something which we have to keep in mind, simply because if we do it in a case where there is only diarrhea, no suspicion of any pancreatic background or pancreatic pathology on imaging or any other background, then the likelihood of false positive is certainly very high. So we have to keep that in mind and then do fecal elastase test on a solid stool. Still, I believe that there are a lot of situations where probably could be patients may or may not really give you a proper sample. They will give you either an excess sample or a shorter sample, etc. But this is something which is to be done, and it establishes what is called as the chymotrypsin-like elastases, CELA 3A and 3B. Less than 100 microgram per gram of the stools is certainly suggestive of EPI. Less than 200 on the clinical background of suspicion makes it likely. That's the test. And then there are other indirect tests, which I believe, sir, you can always enlighten us on that. For example, serum trypsinogen levels or the 13 carbon mixed triglyceride breath test, which is scarcely available, which expect the patient to be in a sitting position for a 6-hour period of time. And then some maybe more modern tests. What physicians will be looking at is the micronutrient deficiency, looking at the pre-albumin transference. Of course, the fat-soluble vitamin deficiencies, vitamin D, very popularly done, and vitamin B12 deficiency also. So I believe that probably as physicians, we will, or diabetologists, we will be certainly looking more on these on the background of a reduced fecal elastase level. So that actually is the workup of a patient where we suspect a EPI. And of course, given that we have probably done a sonogram, maybe a CT abdomen to look at the pancreatic size, morphology, ruling out pancreatic calcifications and other pathologies. So that's what is workup of EPI.
Yes, I think here you rightly spoke about ultrasound or CT scan. So in these patients, the ultrasound or a CT, if done for any other region, I mean, you may be doing a CT for other abdominal region, the pancreas may appear a little atrophic. It may not be as atrophic as we see in chronic pancreatitis. Of course, there will be no calcification. But if the ultrasound says that a pancreas size appears smaller, or if you see on a CT scan that could also be a surrogate which should trigger us to think about, okay, probably this patient also has exocrine pancreatic insufficiency. And we had already discussed about the overlaps. So all the symptoms could be overlapping. We had discussed many times in the last half an hour. And there will be confounders, SIBO,
Yes,
celiac disease, enteric infection. So all these has to be ruled out. Metformin we had discussed a lot. So these things should also be ruled out before we can clinically suspect a EPI. And you had actually elaborately told about the pancreatic function tests. So Dr. Ajay Kumar, would you like to add anything to this?
Add a few words to that?
Yes, sure.
Direct tests, we are obviously the cumbersome, as already told by Dr. Suhas. At the same time, secretin is not available in India. And world over, actually, nobody has been using it for the clinical purposes. They are basically restricted to the research labs for all practical purposes. Now, the indirect tests, one has to look at, I will put, I think very well, Dr. Suhas has talked about fecal elastase, but the other test, which actually we should not forget, the consequences of fat absorption, that is basically fecal fat. Unfortunately, it has gone totally out of fashion. None of the teaching or a corporate or a non-teaching hospital labs is doing this test just because of inconvenience. The inconvenience to the patient, because the patient is already malabsorbing to take that much of fat to test and then to collection And the order of the collection and the lab handling, everything has led on to the fact that people are not stopped doing it. But that remains the cheapest and the best test as yet.
Yes.
Fecal elastase, good test, a bit expensive, but easily available in the last 5 years. But at the same time, you cannot use it to monitor the efficacy of the replacement therapy. So that's the reason it has a limited purpose. But quite often we stick to the clinical assessment before starting the PERT rather than depending totally on the lab test, because they also have on false positivity and negativity.
Yes.
As rightly said, C13 mixed triglyceride test is probably one of the best tests, is probably one of the best, but to my knowledge, it is not available anywhere in the country because of the problems with C13 thing. If there is a difference in that is available, Roop, you can correct me. I think these are the 3 tests which remain the most important, and today's practicality is that fecal elastase is the one which is being used.
Right. So this breath 13 carbon label triglyceride breath test, that is, you have rightly said, not available across the country at a commercial level. But in St. John's Hospital, there is a person called Anurag Kurpat who works on, he's a physiologist who works on stable isotopes. So he and one of his PhD students had recently done this test on pediatric patients. Small number that published in Pancreatology. So they are doing it in these patients, and we are planning to collaborate with them for the adults. So if we could do that, probably that can be used for adult patients also. But right now, as you rightly said, it's not available freely for routine clinical use. And regarding fecal elastase in the context of chronic pancreatitis, actually, I don't think because we in the referral centers always see patients with atrophic pancreas like ductal obstruction. In those patients, you really do not need to do a fecal elastase. But in the context of diabetes, where we don't see too much of a pancreatic morphological abnormality, that could be a good test with a rider. Again, Dr. Rande, Dr. Ajay Kumar rightly said the false negative thing, watery diarrhea, watery stool. So if those things are, and these patients has autonomic neuropathy related diarrhea, metformin related diarrhea, all these things can be there, enteric infection. So we have to be careful while we advise a fecal elastase in these patients. It may be helpful, but if you see the sensitivity and specificity has a broad range, which means that it's a good test, but not the best test. So that is very important to keep in mind when we order this test. There has to be a very strong index of suspicion, very high pre-test probability, and they should not be having the confounders that could lead to a false positive, not negative, like watery diarrhea. So let's go ahead to the next thing.
Doctor,
so we'll work in this patient. Yeah.
So my question is, it's not uncommon, that we see patients on a CT, we find an atrophic pancreas and the patients are asymptomatic. So how do you explain this? You just have a small and the duct is seen and it's totally atrophy and patient has no symptom. They're just normal.
Right.
Explain the
yes, again, so it's probably not a gross atrophy. Again, we have discussed a few minutes back, only after like 80%, 70% destruction or reduction in pancreatic secretion, the patient gets symptomatic. So they may be having some calcification, little ductal stone, not atrophy, but not too much. So they're producing whatever enzyme is required for digestion. And another important thing called gastric lipase. Usually gastric lipase is produced in a very small proportion. But there are studies which shows that gastric lipase may increase in these patients. So that could also take over the digestion of fat. So in those patients, in my practice, I would not prefer to jump into giving them pancreatic enzyme or doing fecal elastase. I look at the nutritional parameters, follow them closely, and with a little bit of inkling of symptoms suggestive of BEI, then I start. But patients who has symptoms but not gross atrophy, then in those fecal elastase may be helpful. Sometimes there could be functional loss. The anatomy is maintained, morphology is maintained, but ductal obstruction can block the enzyme secretion into the duodenum. So in those patients, fecal elastase could be of help in defining PEI. Yeah. Okay, so yeah, so again, I come back to Dr. Sujay. So do you think PERT will work in this? Now we know that PERT PEI is there. It's a major problem. It has all this problem dilemma and diagnosis. Suppose you diagnose it. So will PERT work in these patients?
I think
So
before
do you have any evidence to such?
Before I jump to that, so we've also not too long ago, published comparison of fecal elastase levels in FCPD versus type 1 versus type 2s. And
Okay.
universally, biochemically, everybody had fecal elastase deficiency in FCPD, though not all of them had symptoms. Only a small proportion of them actually had symptoms. And when you look at type 1s and the type 2s, type 1s, about 30-35% had biochemical deficiency. And in type 2 diabetes, the numbers were slightly smaller. Now, I guess whether somebody will respond or not depends on what the type of diabetes is. Are we talking about FCPD? Are we talking about type 1? Or are we talking about type 2? That's number one. Number two, is the patient symptomatic to start with? What's the degree of severity of the deficiency? So I think all of that will finally decide whether somebody responds or does not respond. The challenge and the problem with the clinical trials that have been conducted is they've thought that these things are homogeneous rather than heterogeneous. So had the selection of the patients been more stricter and stringent, I believe the chances of being able to demonstrate clearly that something's working would probably have been better. With whatever evidence we have, you'll probably see that the chronic pancreatitis group tends to benefit to some extent, whereas in type 1, we don't have any data of intervention. In type 2, we have intervention with variable results. Because we know, like I said, if the absorption is better, the incretin effect is better, the GLP-1 response is better, insulin secretion is better, and the glucose levels should come down. And there are some studies to even suggest that the A1C comes down by 0.3 to 0.4. That's not what is shown universally. There are studies on either side, some benefit, some showing no benefit. And that heterogeneity is predominantly because of the heterogeneity of the population that's probably been included in the type 2 diabetes studies.
I think this is very correct. That's what we all feel. So I think, again, this would be my appeal to this whole group. And this is, again, the platform where we can start some kind of RCT with including patients with stringent inclusion criteria with very well-defined criteria. So I think that could be something very novel that we could start in this country, and we have our own data. Because again, for several diseases, you would agree with me, be it cardiovascular, be it endocrinology, be it GI diseases, our patients are different. The disease morphology or disease phenotype that we have are pretty much different from the West. So I think that this is a time where we could start a randomized controlled trial on this aspect and see whether it really works or not. So I think it's already 9. We'll just quickly go on to the treatment. Ma'am, Jayanti ma'am, would you recommend any practical way to initiate for it? Because again, we had talked about the discrepancies, the heterogeneity, the dilemmas in diagnosis. So sometimes it may come into a situation where we don't know, the patient is not showing objective evidence, yet we are strongly suspecting. So does it make sense? Yeah.
So my thoughts on PERT is that I'm very selective, highly selective in choosing. Maybe a couple, maybe half a dozen of cases I may have treated. But if the patient has frank steatorrhea, the typical oily stool, recently we had a patient, probably those are the only patients where I would consider. Not in any other patient. Maybe a fecal elastase test may guide me. And I would consider in a patient who has loss of weight and is not responding to our treatment for SIBO, then those are the situations. But otherwise, I'll be very selective in choosing a PERT.
Yes, I think, yes. So this is something I picked up from a review article. So again, here, as you rightly said, when there is steatorrhea, there is like no other choice. I mean, you can start with PERT with or without gross pancreatic atrophy. And then, so this is definitive treatment with PERT. Now, the other situation is there are non-specific symptoms, weight loss, flatulence, nutrient deficiency, and they meet the risk criteria of PEI. In diabetes, all those long ascending diabetes, insulin requirement. So in those fecal elastase testing they can be started with PERT, and then non-specific symptoms, diarrhea, and meet the criteria for PEI. Now here the patient has an additional layer of diarrhea. So this is where I think it's important to rule out drugs, metformin, SIBO, celiac disease, autonomic neuropathy ruled out, then go for a fecal elastase, and then you can start off with PERT if it is very low. So I think this is the practical way of going about in the general clinical practice. Of course, if we are in a research environment, things could be different, but this is probably ideal or a practical way, not ideal, a practical way to go ahead and treat these patients. So now we know when to start treatment or when to start empirically or based on objective evidence of fecal elastase. So here again, I think Dr. Joshi is still not there. So what are the cornerstones to use PERT? Again, this holds good not only for diabetes, but EPI for chronic pancreatitis, any other cause. It has to be the right timing, which means the right preparation and the right dose. So what I mean by right timing, it has to be delivered in the duodenum along with the food chyme, because when you eat, the food gets accumulated in the fundus, and then because of this fundal and muscular contraction, it will be directed down to the enteral mill. And the antrum, again, this is basic anatomy, has a complex layer of muscular structure. So it will churn and grind the food and make them into chyme of 2 millimeters or less, which crosses through the pyloric channel to the duodenum. And then the pancreatic secretion will come here. So when we give pancreatic exocrine supplementation, it has to go along with the food chyme into the duodenum. Then only the contact will happen at the site of digestion. And that is why the right timing is along with food. The right preparation has to be enteric-coated microsphere or mini microsphere. Studies have shown that mini microsphere and microsphere have the same effect, but microsphere is important. That means it has to be in granules 2 millimeter or less, so that it mixes with the chyme and go to the duodenum. And the right, of course, it has to be protected from the gastric acid, because this gelatin capsule will get dissolved in the stomach. So it has to be enteric-coated microsphere or mini microsphere. And finally, the right dosage. There has been lots of debate about what is the right dose. We still don't know. Different school of thoughts, different guidelines talk about different dosages. But if we look physiologically, if we look from a physiological perspective, the daily pancreas lipase output has been measured to be 600,000, 6 lakhs unit. And we need just 10% of the total lipase for digestion. So looking from that perspective, the minimum daily dose supplementation should be 60 units. That can be divided into 60,000 units, 20,000 thrice daily. Major meals. And that brings us to a starting dose of 25,000 to 40,000. Now we have preparations of 25,000 and 40,000 in the Indian markets. In US, there are preparations of 50,000, 72,000. So here, 25,000 would be an ideal choice or optimal choice, because we have seen the Indian diet does not contain that amount of fat that would require 40,000 or more. So this is something that we can start off with, 25 with breakfast, lunch, and dinner. And if there is a big snack in between, we can add a lower dose of 20 or 10,000 units per snack. So here I'd like to invite all of the panelists, especially the gastroenterologist, Dr. Ajay Kumar and Jayanti ma'am. What would be your recommendation on the dosages? I mean, timing and those things, microsphere, that is pretty standard, but those still we don't know. Your experience and what would you recommend?
See, when our experience in the pancreatic exocrine insufficiency is predominantly in the patients of chronic pancreatitis. And the standard dose that we start with, I mean, normally we say that start with a smaller dose and scale it up. Quite often we have out of compulsion because patients cannot afford. They always, it's a lifelong treatment for them, and it's not easy to, it's an expensive drug. So they try to find out the shortcuts that if some symptoms are better, some are not. But ideally, normally what we like to do is about 25,000 units per meal and 10,000 units per snack. But usually the snack dose is missed, and 25,000 is the usual dose. Very rarely we go up to 40,000 units. And you rightly said, it should be given right in the middle of the meal. And if you need to add more, then you add in the beginning, at the initiation. Then it gets mixed with the food very well, and then microspheres, and then it does the job. So those are the usual doses.
Yes.
Yeah. One thing is, are these all porcine preparations? So I think that's something that
yes, ma'am. We in India we just have the porcine as of
so this
now.
Has to be mentioned to the patient, because I think that's important.
Yeah. And the other practical thing, because as just now Ajay Kumar sir told about the cost and all, patient tends to skip some dose, and many a times patient would skip the lunch dose. They would take the breakfast dose and the dinner. So again, that's why it is very important to know the patient's dietary habits, which of his meals has the highest amount of calories and fat. And if the patient needs to reduce, they can reduce the dose where they have the lowest amount of fat, or they can modulate that diet where the fat content is brought down. So I think this is very important. That history.
Importance of preparation with a medium chain triglyceride, right?
Yeah. So this is how the right doses, but still there has been debate, and there are lots of papers from Europe and US, and even we have published a couple of things where we could show that even at 25 or 40,000, those patients still remain malnourished. And again, these are some of the factors. Of course, fecal fat content we cannot measure, but the size of the patient may be like normal weight or overweight, size of the meals, the nutritional status of patient. Based on these factors, we can tweak around with the dose. We may be able to increase it 40,000 or maybe reduce to 10,000 also, as for so especially if the patient has issues with affordability and availability. So these are a few of the factors that we can use for our help to tweak the dose of these patients. So now again, to Ajay Kumar sir, some practical tips to be followed while on PERT.
So most of the
we had discussed few of them, but again, your wisdom on that.
Most of the things that we talked about, that we can start with a lower dose, say 10,000, and scale it up gradually where the patient starts feeling symptomatically better. And two, it has to be given in the middle of the meal. That's the best way to give it. And people have tried to work out whether you give in the beginning, middle, and end. And the third thing is that if you need to add up, then maybe you can add something just in the beginning of the meal. These are some practical tips, and question is, how do you monitor them? The monitoring, the best is by the clinical thing. Nutritional status, clinical symptomatology, gaining weight. Weight is a very important factor. And then please take care of the nutrition deficiencies. You need to take care of the fat-soluble vitamins. And fourthly, when the patients are not responding, please see to it that their food intake. There's a beautiful paper by Roop's group that you need to see. What happens is, when the patients get used to reducing their food diet to take care of their symptoms, and when you give the enzymes, then they still don't increase their fat. They should take normal fats. Then only it's a benefit of giving enzymes, because then only the fats will get utilized there. And so diet is very important. Taking care of the nutritional deficiency is important. Monitoring is important. I hope I've covered most of the issues.
Yeah. So this is what you just told. If you see, so in this study, actually, what we did, we divided the patients into 3 different groups. There were 2 cohort of patients from 2 different time points. The study group 1 had patients who were religiously taking the pancreatic enzymes as they were advised by the physician for at least 3 months, at least 25,000 of enzyme thrice a day. In group 2, these patients were taking, but they were somewhat irregular. Either they stopped themselves, or for whatever reason, they did not comply to or adhere to the exact dosage regimen. And group 3, they were either not started with the enzyme, or they had stopped for at least 6 months. And we looked at the nutrition based on something called SGA, Subjective Global Assessment. And if you see here, the patients in all the 3 groups, almost 35-36% had persisted to be malnourished. These were the patients who were taking PERT. These were regularly. These were irregular. They were not taking. So that shows that, and even the weight gain was similar for the patients in 3 groups. Even patients who were not taking PERT, there was some weight gain, and many of these patients who were taking PERT, the weight gain was not adequate. And this is where we did a logistic regression, and what turned out was that they were taking low calories. People who were not taking the food adequately, were taking a low calorie diet or low fat diet. That was the single most important risk factor that contributed to the persistence of malnutrition even after PERT. So that's why that Ajay Kumar sir has said very correctly, and this is a very strong message. Patient on PERT should be given to take a normal diet. And why does patient eat less? First of all, we as doctors, nutritionists, healthcare providers are the first one to ask them to take low-fat diet, fat-free diet, which is wrong. They have to be advised to take a normal home-cooked food, fear of symptoms, and then there could be decrease of appetite due to chronic inflammation, depression, anxiety. All this would lead the patient to eat less. So these things should also be addressed while the patients are treated with PERT. So most important is PERT with a normal balance diet without fat restriction, and there has to be dietary counseling. Again, I'm reiterating this, the same thing that Dr. Ajay Kumar just said. And how to finally, I think one more slide, 1 or 2 more slides. So how do you evaluate the optimal response to PERT, and how do you handle if the patient has inadequate response? So Dr. Rande.
Yes, sir. Sir, the response to the PERT will be technically assessed by a very salient features, like for example, the patient, whether he is gaining weight or his BMI is improving, whether his symptoms are coming down, especially that steatorrhea, whether it is coming down, abdominal bloating or pain is coming down, improvement in the overall quality of life, micronutrient levels, which can be certainly measured, vitamin D levels, are they improving? The tests like fecal elastase, they are not useful, they are not affected by PERT. And the breath test, they are actually not, we have not really been doing that because its availability is certainly a problem. We have to ascertain whether the patient is taking the drugs as per the instruction during meals, as Ajay Kumar sir very, can say relevantly has mentioned 2-3 times. If the patient is storing the drug properly, not in a hot environment, etc. And the other important thing is we have to probably uptitrate if the patient is correctly taking the dose also is correct as per the weight, etc. So that is something which I would certainly look at. If the patient is not responding, I will have to consider some other issues, like for example, the small intestinal bacterial overgrowth or bile acid diarrhea. Logically, Giardia, because Giardia is something which is not very uncommon still, at least in our areas. So we have to think of these things if the patient is not responding to the supplements, PERT supplements. That's what actually I would say. Importantly, and what both of you have insisted on, if the patient really goes for a normal diet, no reduction of fat, ample normal diet he's taking now because he's on enzymes, then there is a likelihood that his diabetes might, you can say, actually worsen. So we sometimes put the patients on continuous glucose monitor to better handle the glycemic control in these situations.
Yes. And 2 other important points is like these patients often have constipation, diabetic neuropathy, and we have the tendency to use high fiber or high fiber diet and fiber-based laxatives, so they can bind to the enzymes and reduce their action. So that could also be one of the factors of inadequate response. Antacids are used very commonly in clinical practice. So antacids can also bind to the enzymes and then reduce it. So these things should also be kept in mind when the patient comes back telling that the PERT has not worked well on them. So
Yes, sir. And a lot of patients, sorry for interruption, a lot of patients actually come back because they are diabetics. Or they are already on polypharmacy. So this adds to the burden, and the price, of course, remains a concern for quite a few of the patients.
Yes, I think, okay, cheers. Okay, so maybe I think this is the end of the presentation. So I think let us listen to just a single sentence or 2 from all the panelists. What would you think as a closure remarks into this problem?
And sir, there are 8 questions are also there in the chat box. You can just check.
Answer that, yeah.
Okay. Okay. Yeah. So, yeah, Dr. Sitaranjan Yagnik. Okay. We published a number of papers about EPI in different types of diabetes patients in India by measuring serum immunoreactive trypsin and fecal chymotrypsin. Okay, I think this is just a comment, but I think can the participants speak, Pradipta?
No, sir. No.
No. Okay. So I think that's a very good thing, welcome thing that you have used a different way of doing that. Okay, so Dr. Manish, what are the lifestyle changes required for patients with EPI in diabetes? So any of the panelists can take it up. Lifestyle changes with EPI in diabetes.
There is a lifestyle I think that you need to build up the muscle mass. Other than that, directly there is no such thing, and you need to do exercise regularly, which all the diabetics are advised to. And of course, I think the most I think there's another question which I can take up simultaneously. Role of antioxidants and probiotics for EPI. I think there's no role for that in this. Just one word.
Yeah. And what about pancreatic fat by Dr. Chittaranjan again? Ectopic adiposity function.
Yeah, sir, there is a lot of discussion about this, the infiltration of adipocytes into the pancreas. They can certainly put in a lot of free fatty acid environment, right? Lipotoxicity, local lipotoxicity for the beta cells. So it can always be a challenge. And there is a thing called as exactly the description, the short form is called as what is called as Pandora. And this has actually found mention in the recent discussion for the academicians. And Pandora is nothing but pancreatic disease originating from intrapancreatic fat. We in India are appreciating obesity chiefly as visceral obesity or central obesity. And just like the fatty liver, we discuss fatty pancreas and maybe even fatty kidney, etc. So this is an element which is certainly coming up as a kind of a mixed entity with these different pancreatic problems, maybe more so in the obese diabetic people, centrally obese people.
Yeah. So the next question is by Dr. Archana. Guidelines for steatoria EPI type 1 diabetes child. So not for this specific entities, but there are several guidelines by the societies on EPI in chronic pancreatitis. And I think this guidelines can be used for patients with EPI in diabetes. Still, the specific guidelines do not come up. Are you replacing ADEK patient? Yes. So the patient needs nutritional supplement, at least in the early stages. ADEK can be replaced. And quickly, the last two questions. Does the weight of patient affect the course of therapy? Any OHA to be avoided in EPI? Dr. Sujay, you want to take this up?
I think, again, here it would depend on, the kind of diabetes that we are talking about. I would avoid the GLP-1s and the DPP-4s in case of a background of a pancreatic disease. But if it comes to type 1, you are not going to use any OHAs anyway. In type 2 diabetes, the only OHAs that probably, I would avoid would be something like an alpha glucosidase inhibitor, which would probably add more fuel to fire in terms of other causes of, GI intolerance. Otherwise, there is no reason not to use any of the other agents.
Yeah. Okay. And then in PEI, we focus on steatoria, rightly so. But what about proteinuria, criteria? Does it have any contribution to malnutrition? Basically, the most important enzyme secreted by the pancreas is lipase, because it even in a normal person, the lipase degrades to as low up to 1% as they pass along the large intestine and small intestine. But for the protein digestion, there are lots of aminopeptides in the gut intestinal mucosa. So even if there is exocrine insufficiency in pancreas, the intestinal mucosa, hydrochloric acid, salivary amylase take over the function. So protein, loss of protein and criteria is there, but not as bad as steatoria. So, and they can be easily replaced by nutritional management. And I think this question is for Jayanti ma'am, the last question, MCT in diet. Comments, please.
Yeah, that's what I was alluding to, that although we were discussing about replacing of fat, I think medium chain triglycerides are absorbed directly. They don't need the missile formation. So olive oil and coconut oil are rich in that. So I think preparations, we always advise, at least in FCPD and patient chronic pancreatitis, we ask them to be on a diet, being the fat being replaced with olive oil or coconut oil because of the direct absorption.
Yeah. Okay, I think there are no more questions, and it's almost 9:30, and I don't want to keep you back from dinners. So I think we'll stop here, and thanks to all the panelists for this brilliant discussion and taking up the questions and bringing up your perspective. And I think Ajay Kumar sir has left. And thanks to Pradipta and the whole Juventus group for bringing this together. And I'll stop here. Any final comment from Pradipta and your team? Then you can.
Wish you all a happy new year.
Thank you, sir.
Thank you, ma'am.
Thank
Thank you, same to you.
Thank you so much, sir.
To all of you.
Closing remark.
Happy New Year, sir.
Yes,
Happy
sir.
New Year.
Thank you. Thank you. Same to you. Happy New
Karthik
Year.
will give the closing remark, please.
Yeah. So thank you all for
Yes,
joining
Karthik.
us today. Thank you, sir. Thank you all for joining us today for this insightful webinar on EPI. We hope you found the session informative, and a special thanks to Dr. Rupjyoti Talukdar for providing valuable insights. We are also deeply grateful to our engaged audience for your active participations and thoughtful questions. So this webinar was powered by Enzilo with EMMS technology. Thank you all. Thank you very much.
Good night. Good night, all.
Thank
Good
you.
night.
Happy New Year to all.
Happy New Year.
Thank you,
Happy New Year, sir.
and good night. Good night.
Good night, all. Thank you.